Hi, everybody. Good morning, good afternoon, good evening. We're so happy to have you here at the CGIG meeting. We've been looking forward to this topic for quite some time, and we're really grateful to the presenters. As you well know, quality and program fidelity are so important to the care group implementation and development process, and really make a huge difference in your results, your ongoing sustainability of behavior change. So today, Food for the Hungry, World Renew and Curamericas Global are going to share with us how they put their quality assurance practices into place. They'll share different aspects of quality assurance, how they generate local buy-in, ongoing monitoring, and periodic process evaluations. And they've set aside plenty of time for Q&A, as well as for time for you all to share your experiences, tips, and tools. So our speakers today include Karen Calani, who's Senior Technical Advisor for Health and Nutrition at Food for the Hungry, Violet Barungi, who's the Health and Nutrition Specialist with FH Uganda, Moses Injirio, who's our Institutional Capacity Coordinator at FH Uganda. We've got Sadoc Aguilar, Country Director for Guatemala at World Renew, and Barbara Muffoletto, Program Manager for Curamericas Global. And just thanks so much to all of you. Please continue to introduce yourself in the chat box on the side as you arrive. And I think we're going to put up the poll next. Turn that over to you, Kim.
Hopefully you guys are seeing that poll. Are you able to see it?
I can see it.
Can we get a thumbs up from others or an acknowledgement that you can see that? Okay, I see some people starting to vote. There should be 2 questions. I'll give us another like 2 or 3 minutes. Looks like 7 out of the 12 of us have voted. It doesn't look like it's counting co-host as voting. All right, I think that we're probably close to being done. If you feel like you need a little more time, you can signal to me somehow, raise your hand, open your mic. Otherwise, give you another couple seconds and then we'll wrap it up. Okay, I'm going to display the poll results and I think that Karen's going to move us forward with that.
Okay, good morning, everyone. Can you see the results there on your screen? So we have quite a mix for our first question of how do you feel your care groups are doing with quality assurance? So some are like, what is that? And some are pretty good to awesome. So that's a good mix. And then using a QIVC, a quality improvement verification checklist. It's just, we're complete opposites, right? So some have no idea what it is, and some wouldn't do any project without them. So I hope today that we'll have some good conversation to kind of talk about how we do Q&A or QA and yeah, learn from each other. So I'm going to, I think I'm going to my presentation. Okay, hang on a second. There we go. Okay, so today from FH, we're going to be talking about local buy-in for QIVCs for quality improvement and verification checklists. So we're, Violet, Moses, and I are going to just be sharing FH Uganda's experience introducing a quality assurance tool and to improve the quality of their care group meetings and then better align to the care group model. So, oops. So FH Uganda, these are our work areas. We work with health and education care groups together. So, or they're not together, but our education activities are also carried out through care groups as well as health. They're separate groups, but they, yeah. Our project areas include Kitgum, Queen, Kole, Namatumba, Mbale, Ajumani, and Lamual, sorry. The two kind of light green areas to the north are where we work with refugees. And then the other green ones are other areas more to the south and the east. We have 15 paid FH staff. We're working with 2,412 volunteers and reaching nearly 16,000 families. There we go. So the question, Violet, you were going to go ahead.
So
sorry.
The next question is, why did we have to add in a quality assurance tool? And apparently we are using the QIVC. One, we wanted to implement the CG model as it is given in the care group model that was, I think, developed by, I think one of them was Mary DeCosta, I'm not yet sure, but we wanted to follow what exactly was in the cascade group model or care group model and following it. And if you see that one of the things that it has the pre and post module assessments, as well as the QIVC is conducted to make sure that we have, we check the quality of our staff, the training they are giving to the volunteers in the field, as well as the quality of training the volunteers are giving to the neighbor circle mothers. And the second issue was about we didn't have exact data to prove that these trainings are actually being done in an effective and efficient manner to produce results or to see outcomes. So wanted to see if we are conducting these care groups, is there any benefit to the communities that we are actually implementing? And how are we seeing this benefit? How are we getting the events collected through these care groups? And so we started using both the care group registers and as well as the QIVC to even see who is missing, how many of the neighbor circle women are appreciating this kind of module. And then the other part was to improve other module improvements. For example, we wanted to see that the neighbor circle women feel that they are also given an opportunity to air out what weaknesses they're seeing in their leaders, much as their volunteers, but also to air out more on what would add to the care group to improve it. And we have seen this giving us a lot of results in making sure that these care groups actually meet frequently, and it's kind of like a motivation factor, as I'll explain. Next. So how did we get started with the QIVCs? We made sure we had found out that some of the clusters had actually started the care grouping. And so what happened is that whenever they would finish or are going to start the module that is going to be trained, this is when we would train the new module and also train our FH staff and managers on how to use the QIVCs. So it was done in phases for each cluster or project area that was going to begin a new model in the care groups to make sure that we train the new module as well as the monitoring and evaluation aspect, which involved the QIVCs. The next was we had to organize a group of training for all staff who were actually implementing or going to implement the care group modules. And since most of our areas of operation are now implementing the care group module, we actually clustered the health and nutrition community development facilitators to actually train them in detail on the data collection tools as well as the QIVC. We also provided support to a smaller group of staff at the beginning, those who are joining in FH. We make sure that once you're actually enrolled into the FH and you're going to be a promoter or what we call a community development facilitator, we make sure that we give you a training that is fully covering the care group module, the types of modules that we are going to be teaching, the data collection tools, as well as the QIVC. So our promoters, and these are our staff who train the care group volunteers in the communities, are supervised by our managers, the program area managers. This is done twice a month. And so we have a surprise visit and also a one already elected date for having this visit where the program area manager conducts the QIVC. So one is a surprise and one is on site, which is already determined by the FH staff and the program area manager, who is in this case, the supervisor. Then the volunteers are supervised by our staff once every 3 months. Why? Because each staff has around 5 to 8 groups. So that gives us promoters having care group volunteer lead mothers between 60 and probably more than that. So we make sure that the volunteers use this QIVC with the FH staff use this QIVC with the volunteer at least once every 3 months. Yes, we can go to the next slide. So the challenges we have experienced using this QIVC, one, during the lockdown for COVID-19, of course, we're not able to get some of the lead volunteers and also to implement these care groups. And so we were not actually conducting the QIVCs. Secondly, both the program area managers and the volunteers themselves have expressed that the assessment tool is very long. We all know that it has around 46 questions. So the time it takes to administer it, get feedback, and then you review, make plans for how to change and the next appointment, it's quite very long. Then balancing time for administration work and supervision visits for our program area managers is very difficult. The care group model needs to have its own supervisors, I think, who report to managers, but because we, in terms of budgeting, we find that our program area managers are the ones doing these supervision visits and conducting the QIVCs, which sometimes takes a lot of time for these program area managers. Then we have quality feedback sessions with the promoters, sometimes done in a rush, and sometimes they are postponed. So we have seen that sometimes quality feedback is not given both to the FH staff as well as the volunteers because it's kind of in a rush and due to the tool being very long. And then making use of previous QIVC scores to track progress. Most times the supervisors take little or no time in reviewing their previous assessments. So they don't kind of have where they have written to follow up or to do kind of information, which can help them to check the improvements registered by the promoter. So this is one of the things that we want to streamlined very well to make sure that we have data. We want to log this into a digital platform so that we have data and which the staff can easily capture, and also the volunteers can use to have this rectified. So how do we provide solutions? I don't know if Moses is on track to come in. Moses? I think he's not. Okay, so the solutions, one, we have provided further refresher courses for using in QIVCs. We have gone cluster by cluster to actually make sure that our program area managers are in these trainings, as well as the staff, to make sure that they have refresher courses on QIVCs every quarter or every time that a new care group module is going to begin. And we have made this an effort to make sure that also our staff go back and have refresher courses or trainings with the care group volunteers. And we have begun looking back at previous courses. Like I said, we have developed kind of a software database where we want to make sure that comments and scores from the staff and the volunteers are actually well documented, and then they are used for the next or subsequent kind of QIVC conducted. We want to make sure that we make modifications to that checklist to make sure that we also shorten it. And we are supposed to get approval from the GSC, our Global Service Center team, to make sure that they can reduce this too, so that it gives us time for feedback and then qualitative reviews. So we want to create a shorter version for also the volunteers. One, that the modification should be done for our staff, but for the volunteers, it should even be rather shorter. The basics of what we want to see from a volunteer conducting a session with their neighbor circle women in the field. Next slide. Have we seen any improvements using this QIVC? Yes, we have, because we have seen a higher turnout of meetings for volunteers. This is like a motivating factor. That's what we noticed, that when you use the QIVCs, it motivates the facilitators, who are the staff, but also even the volunteers, and then the beneficiaries, especially for the volunteers. They are given positive, if you give them positive feedback, it acts like a motivator and relevant training content to these beneficiaries. Most of them haven't gone to school, so by giving them this and trying to make sure that they are doing it in a quality manner, it has motivated them to even think that they are going to school. So they are impressed about that. The next is that there's improvements in how the QIVC is used because of the different feedback we are getting about the tool and the support from the managers. We are seeing that, and also the schedules that we have put in place, kind of like guidelines on when to use the QIVC. We have seen improvements in how the QIVC is actually used. We also have strengthening relationships between supervisor and supervisee, as well as the volunteer and then the neighbor circle women that we are having. Remember, this QIVC tool is kind of like a feedback, 360 feedback. We have a session where even the neighbor circle women will let us know how the volunteer is actually delivering the sessions. And this has helped them build a stronger relationship on what or where they need to have change and improve the whole group sessions. It results in further professional skills development, especially for our FH staff. We have seen them develop in this methodology. One of the things that I had put in our chat box is that because government, we roll out these modules and we do joint monitoring with government stakeholders, they were impressed about the care group module. And as such, FH Uganda influenced the new, what we call the MICAN guideline that has been put in form of care. It has been introduced as implementation through care groups, and it's maternal, infant and young child and adolescent nutrition guideline. It's a flip chart, and they're going to have education sessions in form of care groups, implementation, and this was because of what they have seen in the fields. So this QIVC also helps in identifying further training needs for both the volunteers in the field as well as our FH staff. And because we are following up the feedback where the staff and the volunteer identify needs that need to be improved, areas that they need improvement. This is where our staff come in with a specialist, and Moses, the capacity building specialist, we come in to actually notice these gaps that need further training, and then we can continue to develop the capacity of both the FH staff and the volunteer. Over to you, Karen.
Okay, thank you very much. For our lessons learned from this experience, and just a few things that came out is that for when you begin implementation of a QIVC mid-project, phasing it in allows small groups of staff to be trained and then supported as they get started. So you're not trying to, cover 100 community facilitators at once and trying to get everybody going, but small groups, little by little, kind of helps make that rollout smoother. To create an effective QIVC, it's really important to include those being supervised in the process to gain their perspective on what to include in the list. This is, can further improve buy-in. Increases transparency of the supervision process, and it sets clear expectations for performance. Staff in this experience commented that the list was too long. It was a little difficult to give the feedback. So hearing that helps us to refine the tool and make it more effective for monitoring. And then finally, providing regular refreshers to ensure effective use of the QIVC is important, and you can include supervision tips, techniques for giving feedback and receiving feedback, and then using data, using your information from the scores to make decisions about how to help support staff or volunteers. So that is our experience. And I think I'm going to stop sharing, and Sadoc is going to be up next, I believe.
Yeah, good morning, and thank you everybody for participating in this presentation. I'm going to share my screen now. Can you see the presentation?
Yep, that looks great, Sadoc.
Okay. Right, so I was invited to this meeting to speak a little bit about the experience we had in Guatemala with the implementation of our maternal, newborn, and child health pilot project, and how the quality control helped implement this this model with one of our local partner organizations. So in the initial context of our project, what we'll renew approach is to work with local organizations. We don't do direct implementation, but we support partners in building capacity so they can do community development in their regions. So we decided to work with our partner Adib, who has been a partner of We'll Renew for over 25 years now. This is a really small grassroots organization with only 2 full-time staff people, 1 director and 1 ag specialist. The partner had experience working in sustainable agriculture, doing some preventative health, community organization, and adult literacy. When we talk about preventative health, really their main focus during the last years was mainly medicinal using medicinal plants to take care of some of the health issues in the community, but not really doing a robust child survival program or using a model like the care group model. So that was our starting point for this project, and it took about a year to really start, or a year and a half to really start implementing the care group model with this partner. So it took time to really to get the training. We received support from Food for the Hungry regarding the care group model, and then started organizing in the communities, meeting with the health authorities in the region and so forth. So the goals of the project was that we were trying to build organizational capacity, not just with a local partner, but also with the World Renew staff here in Guatemala, as this was our first experience using the care group model as well. And of course, the other goal was to improve children's health and decrease malnutrition in the region. So Guatemala has one of the highest stunting rates, and the region in which we're working with, which is in the Department of Alta Verapaz, specifically in the Polo Chic region, has significant stunting rates within the community, right? So how do we adjust the care group model to make it work with the resources that we had? So yeah, we tried to be very true to the model. And so we had one coordinator, which in this case, I took the role of coordinator. We had one supervisor, which also had a role of promoter. This supervisor was hired by World Renew, but worked directly with the local partner. And then we had one promoter. At the end of the project, we had reached 5 communities, about 6 care groups, 54. We had trained 54 care group volunteers, and we had 42 neighbor groups. So that was what we were able to do during the 3-year implementation of the pilot project. So how did what were the quality controls tools that we used for this pilot project? As I said, we tried to be true to the methodology that was presented in the manual. So we used the QIVCs, coordinator, supervisor, the QIVC for supervised promoter, and from promoter to care group volunteer. At the beginning, we would use these tools monthly. We thought it would be a good idea just to get to familiarize with the tools, and also it will help strengthen the capacity of the supervisor and the promoter that were supporting the project. But as the project continued, and by the end of the year, and because of COVID, we decided to use these tools quarterly. Actually, for during the time of the pandemic, where there was the lockdown, the QVCs for coordinator, supervisor were done remotely. And because I was the coordinator, and we were, my offices are like 8 hours from the project where it was implemented. Also, at the beginning, it was done, the monthly reporting was done monthly as well, right? So it was done remotely as well. That's what I meant. So we had quarterly reports, and we had key performance indicators, as you might see, and we had field visits. When we were able to go to the field, we would visit the communities, the volunteers, the supervisor every quarter at least. So what were the barriers that we encountered with using quality control? First of all, the literacy rate among women in the communities. So here we're talking about the care group volunteers. There was a slow implementation. We had a delay in starting the project. So QIVCs were actually using by halfway through the project, right? So it's all the stage that I mentioned that we had to prepare. But after after we started implementing the project, and we still were not using consistently the QIVCs, right? So there was like a learning curve there, and regarding quality control using these QIVCs. As I mentioned, there was no consistency at the beginning, where we were expected to, or the expectation was to do some of these checklists every month with the caregiver volunteers, with the supervisor, but sometimes that wasn't the case, right? And then there was the language barrier, the understanding of the questions in the checklist. We work in communities that the main language is the Quechua. We have the checklist in Spanish, so there was a process in which we had to kind of go over those checklists and discuss them with the promoter and the supervisors and the volunteers regarding what we were monitoring or what we're assessing with the checklist. So how did the quality control help with the pilot project? First of all, well, we felt right at the end, by the last year of the project, we felt very confident using the QIVCs. Right? We were doing it more consistently, and we were actually using them. We're pretty helpful for the feedback with the staff and with the volunteers. The QIVCs help determine what to report for the key performance indicators. For example, we had the key performance indicator of number of CGVs that we're managing adequately, their neighbor groups, and we use the QIVC to determine, okay, how do we, which CGVs are really doing their work or their role properly, right? In the manual, it suggests that in the checklist, they should score 80%. And we noticed that it's not really hard to score 80% if you look at all the questions that are being asked. Right? For instance, they're asking about, there's a question regarding if the caregiver volunteer uses proper wear or proper dressing when she does the meeting with their neighbor groups, and that isn't really hard to comply with the experience that we had, according to experience that we had. But there were certain aspects in the checklist that we really pay attention to, especially when it talked about ways in which the volunteer did the training with the mother, with the mothers, things like, did they use participatory tools, like stories and sketches and games, or things like, did they make the right questions to foster discussion? So those were the things that when we did when we use these tools, we're checking, right? So it's not just using the score of 80%, but actually paying attention to what they were doing and what we were responding to yes and what we were responding to no. So depending on that, we would reinforce those aspects with the caregiver volunteers, with the promoter, and with the and with the supervisor. The project was really small, so there wasn't really a lot of data to be analyzed, but definitely it was something that helped us gain confidence in implementing the model. Right, this was really new for everybody involved. Using quality control, the checklist helped strengthen the organizational capacity. So as I mentioned before, the goal of this project was for the partner organization, CBO, to be able to use this model in the scale that they have the capacity to do. So, for example, with the coordinator in that case, it was me that was using those QIVC. Was really helpful for me to supervise the supervisor and also help the partner build that capacity. The same with supervisor and with the promoters that actually helped us make some decisions regarding how to use or what to use as, or who to use as promoters. We initially started using community facilitators, which were volunteers of the Ministry of Health, as promoters, because we wanted for those, we wanted the promoters to be locally in the community. Right? But as we were working with them and training them, but also doing the checklist, we determined that they weren't really delivering. And I think that was using the QIBCs really helped us determine that quantitative, quantitative wave and not just qualitative. So from community facilitators, we moved on to deciding that we needed to hire a promoter that was a paid staff by, in this case, the project that Global Renew was funding. And then, of course, it just gave clarity on measurement, performance, and improvements to do to the staff that were involved. And then I think it's also helped us with a scale-up plan with the new community-based organization. So the idea was to replicate the experience. The idea is to replicate this experience with another small partner organization that works with Global Renew in the Petén area, similar communities as the partner that was involved in the pilot project. But what we learned through this pilot project, especially using these quality controls and the lessons learned that we got from these tools are going to be helpful as we do this scale up one with the new partner organization. So what are some of the next steps that we're thinking about is, of course, we want to continue strengthening the quality control with the partner, ADIP, and also with the new partner up in the Petén area. And we want to experiment with digital tools such as COBOL and Google Forms for quality control checklist on the list. Right? So all these, we think these tools will allow for a better way to store the information and also to analyze the information and just save also some of resources of the partners of the project. We're in stage of developing these tools. We haven't yet applied them, but it would be interesting to know if other organizations or representatives of other organizations that are in this call will kind of share their experience with. Thank you very much for your attention, and looking forward to your questions, to your comments. Thanks.
Thank you, Sadoc. I believe that Barbara is up next. Barbara, you getting ready?
Let me get my screen shared on just 1 second. Okay, can you all see my screen?
Yes, we can.
Excellent. So good morning, everyone. My name is Barbara Muffoletto. I'm a program manager at Curamericas Global. And today I'm really excited to share with you about our periodic process evaluations that we've been conducting with our project in Kenya, KICOP, whose representatives can join us a little bit later. I wanted to start out by first making sure that we are on the same page with what we're talking about when we say a process evaluation. Many of us are very familiar with an outcome evaluation, and That's where we look at for changes in health outcomes, such as hand washing, health facility delivery, exclusive breastfeeding, and whatnot. A process evaluation is different. It evaluates the program itself and looks at the quantity and quality of the products and services provided by the program. So it's really looking at to what extent is this program being implemented as designed, as planned, as outlined in our detailed implementation plans. To provide one illustrative example, an outcome evaluation may be looking at the program's effect or changes on health outcomes such as exclusive breastfeeding, where a process evaluation would look at things like attendance to care group lessons on exclusive breastfeeding, or the percentage of neighbor groups that provided space for mothers to practice exclusive breastfeeding during the lesson. So checking to see what the checking to see how the program is implemented and if certain criteria are met. What's really great about a process evaluation is that it explicitly states the expectation for the various programmatic aspects of an intervention, and then measures and sees to actually what extent those aspects were met and actually carried out in the field. So our project in Kenya has really benefited a lot from conducting these process evaluations. It has helped us understand and build on our program successes. It's also understand and help us address our program failures. So for example, back to our exclusive breastfeeding example, if we find that, we've been doing care groups for a year and the exclusive breastfeeding, prevalence of exclusive breastfeeding is just remained stagnant over that time. Perhaps it was, an issue with our conceptual model, with our theory of change, or perhaps it's because the program wasn't implemented as planned. Perhaps maybe we skipped that lesson by accident. There was a holiday that week, no one attended. So really understanding the process evaluation helps us understand our health outcomes and our changes in our health outcomes to see if it was maybe because of the program or because there was, something else that was going on. So it helps us, understand our successes and failures. It also helps us identify and fix both people and system problems. So, staff, volunteers, community actors who maybe need some more training or support. We've seen that a lot already this morning with mention of the QIVCs. It also helps us see common problems that groups of people are having, such as our care group volunteers may all be having issues with, filling out the attendance register. All of them are forgetting. And so we know we need to do additional training on that aspect of the care group lesson and their responsibilities. For KeyCop and Curamericas, it really helped us improve our internal tracking and data systems. And this was in part because we needed to really use those systems in order to conduct our process evaluation. And so we were able to see kind of what the gaps were, how well they were being used in the field, understanding on various levels of staff and volunteers. It also provides a route for us to better replicate our program. Process evaluation really helps you understand what your program is in reality, not just what it is on paper. And so having that understanding really helps if you want to build a similar program. And lastly, it's very useful with accountability. And that is because the process evaluation requires that expectations are explicitly stated for various systems, for various positions. And then we're actually going to measuring the extent to which we're meeting those expectations. And so by completing that measurement and reporting on that, there's just increased accountability. Even asking the right questions to people about their positions can help increase accountability. So for our KeyCop process evaluation, we have 3 catchments there, and we completed a process evaluation within the first year of each catchment, program rollout in each catchment, and our goal is to complete one once a year going forward. We've done that already once in our first catchment we started with. Our last process evaluation addressed 17 research questions that were spread into over a quantitative assessment and a qualitative assessment. The quantitative assessment pulled from the QIVCs, which we've talked a lot about this morning, as well as the supervisor report. And the qualitative assessment was collected through focus group discussions with promoters, care group volunteers, and neighbor women. We didn't have a supervisor level, so those were our three main levels within our care groups. Going first to the quantitative assessment through our QIVC report. So these are, kind of consolidated view of our research questions that we were able to answer from our QIVC report. So first, we looked at, well, are we even conducting quarterly QIVCs for group meetings? Are we conducting them for home visits? And then, assuming the answer is yes there, to what extent are we adhering to the standards that are laid out in our QIVCs? What kind of scores are our promoters and our care group volunteers getting on these QIVCs? And then bullet point 3 and 4 are very are similar in that you see it in the bold terms that says most important aspects, and it's looking out to what extent are we completing the most important aspects of care group meetings and the most important aspects of home visits. And this is because I think, as it's already been mentioned here a couple of times today, the QIVC can be really, really long. I know the one that was shared was 46 questions. And in our first process evaluation, we pretty much looked at, every set of pairing of questions or every question. And so we had all this data to look at, and it became really overwhelming. And so with our second process evaluation, we created groupings within our QIVC on facilitation skills, on core meeting components, on mastery of lesson content, and those three groups come together were called our most important aspects. And this allowed us to kind of see if, the overall scores, but then are they scoring well on these things we deem most important, but then also saw the ability to disaggregate that data into facilitation, core meeting components, and mastery of content to be able to, still make meaningful changes in our program. The second part of our quantitative assessment was looking at the supervisor report. This is, the final piece of the register. So you start with the neighbor group register that rolls up into the care group register, which rolls up into the promoter summary sheet, which then rolls up into the supervisor report. So this gives you information on attendance, on vital events, things like that. And so we asked, are we even completing these supervisor reports twice a month? And this is a supervisor report that includes data on not completing the supervisory report. Are we completing the home visits twice a month? And are we completing the care group lessons or neighbor group lessons twice a month? And then we also looked at, attendance rates, and the care group manual says that you want to have an attendance rate of 80% or higher. So what percent of the lessons, the group meetings have that percentage? So to provide one example of, the data we had and how we kind of use that. So here is, our home visits completed by care group volunteers, and the percentage of those home visits completed. So you see this blue bar here is the percent that complete home visit 1, and green bar home visit 2. Our program was set up in that after every group meeting, which happened twice a month, each care group volunteer then went and visited the home of the mother. So we have these clustered under promoters. So these are promoter 1, promoter 2, promoter 3, etc. And then this is the percentage of home visits completed by their care group volunteers who fall under that promoter. So before we started the process evaluation, we assumed that home visits were being completed on a regular basis. So this was just, part of our program. Of course, 100% of home visits are being completed twice a month after each lesson as planned. And when looking at our data, we saw that, it's really only around 1 out of every 2, and that's also spread, pretty equally between home visit 1 and home visit 2, which was interesting. And so this is a good example of a system problem that that's a common problem for across the program, where we need to provide more training, more support, clarify expectations. And I'll go more into this issue and how we dealt with it later on. Pivoting now to our qualitative assessment, here's our kind of a condensed view of our research questions that were covered here. We used focus group discussions to find how promoters, care group volunteers, and neighbor women felt about their involvement in care groups, lessons and support they receive, the content and structure of care groups, the current state of home visits. And then for our facilitators, who are promoters and care group volunteers, we asked them, how do you feel about your facilitation abilities? And how do you feel about your ability to collect and manage data? So now I'm going to just briefly go over just a few examples of some takeaways that we got from the process evaluation, things that are going well, ideas for application, and then an issue that really came to light through this evaluation that we were able to now better understand. So, I think one of the first slides I had, is like the process evaluation shows what's going well. It helps us understand our successes. And one thing we found out is that, data management by promoters was actually going really well. We thought that would be a huge challenge. There's lots of data, it's new systems. Our promoters are part-time, so it was a bit concerning, and it confirmed both through our quantitative data with the amount of data being submitted and the quality it was submitted with, as well as our qualitative data, what we're hearing directly from our health promoters, that data collection and management was going well for them. So I'm good there. We also, primarily through our qualitative section, found some ideas for innovation. And these are things that were not part of our program plan that groups started on their own. So just two quick examples is some groups started using their care groups and neighbor groups as savings circles, where each woman brings a small amount of money. They pool that and give it to one woman in the group every meeting. So it's, encourages them to attend. It also is like a way for women to get like a larger sum of money to make bigger purchases for, like, I don't know, a farm animal or something like that. The second example was interesting for me in that it was both an issue that was raised as well as a solution that was provided on like separate sides of a project site. So one of the issues that came to light was that the participants said that a lot of their fellow participants were often late. So, our neighbor women were arriving in hours, sometimes 2 hours late, and the facilitator would sometimes wait for them to arrive there. So, a lesson that was maybe supposed to take an hour out of someone's day is now taking 2 or 3 hours. And it became like a much bigger burden for the participants to attend because it was such a much bigger time during their day. And so that was happening on some parts of our project site, where on another part, we had a group actually set up a system where if you were late, you had to pay a small amount of money, or if you didn't attend, you also had to pay a small amount of money. And then they used those funds to buy snacks for the group as they went forward. So it was really cool seeing, how sometimes issues were presented, but then sometimes solutions were also presented during the same process. So we had a lot of lessons learned through the process evaluation, things we wanted to change in our program. Or address in our program. I wanted to just share one specific example about the home visits not being completed. This is the data I showed you earlier. And so what was really cool is we saw this in the quantitative data. And I think without the qualitative data, we would have made a lot of assumptions as to why this was and how to fix it and how to address it. But our qualitative data really helped us flesh out this issue and better understand it. It turned out to be a fairly complex issue. So I think my initial assumptions were that, they just, don't really understand they're supposed to be doing home visits. And they don't think it's worthwhile. It's awkward, it's uncomfortable, something that maybe they don't enjoy. And we actually found that that aspect of the home visits for both promoters and care group volunteers was not the issue. They felt the home visits were incredibly worthwhile. They understood the value and understood it was part of their responsibility. What was actually preventing us from completing the home visits were other things. One is that the care group volunteers felt they had a lack of credibility. They said, I don't have a badge, I don't have a t-shirt, the husband doesn't trust me. I'm not being allowed into the home in order to complete the home visit. And what I love is when they, mention these issues, they often mention solutions too. So as I already said, the badges, the t-shirts, they also recommended that we talk with community leaders, talk with the husbands, get everyone on board so that when they arrive and want to complete the home visit, which is part of their responsibilities, they are allowed into the home. The second one I thought was really interesting, in that a lot of CGVs mentioned that they had too many visits to complete. And they also brought this issue to light for us, in that they said that the care group structure is set up in a way that actually discourages attendance to the group lessons. And this surprised us at first. And the way they explained it is that, well, if I'm a care group volunteer and I have 20 home visits to do a month, those are the home visits that come after every lesson. I also then need to do a home visit to each woman who's absent from the group lesson, right? And so, my 20 visits, if I have, half of my women are missing their group lesson, that's, becomes much more home visits during a month. So with women feeling like they don't necessarily always have the ability to leave the home, they need permission from their husband, they're not being paid to go to the care group lessons. Sometimes they go and it can take hours because of tardiness issues. They don't come back with anything. They don't come back with money, with food, with, aqua tabs, things like that. They often had trouble leaving their home to go to the group lessons, and they knew that it could cause issues between them and their partner. And so with that, it's like they might as well just stay home, knowing that they'll get the same lesson from their care group volunteer in the comfort of their home, really at their own convenience with a shorter time commitment. And so this ended up in making it so these care group volunteers were being required to do a lot of home visits, and it was just too much demand on their time. And it just kind of was this kind of negative cycle. And it's something that we're still, we've addressed through talking with our community leaders, talking with husbands, restating expectations, but just being aware that, sometimes this structure, the cascade structure, can also have, some parts of that setup that can be, deterrent for attendance. So anyway, I'm happy to talk with anyone about this after again and kind of digest it a bit more, but I think I'm probably getting close to time. So I wanted to just share a quick couple of tips and lessons learned. One, I want to say that we completed all of our process evaluations, 4 of them now, through the use of practicum students and interns, guided by myself as well as our field team on the ground, Kevin and Ann. We also, so this is, very feasible. You can, the practicum students are free. You can use UNC Gillings, UCLA, public school, fielding in public school. Also, I want to say that we developed a lot of data templates during the first process evaluation, which I'm happy to share after this. We adjusted them after the first process evaluation. And so I recommend using the systems you have and then adjusting them so that your next process evaluation is easier. At that point, you'll have your research questions defined. You'll know what data you're looking for. Make your templates and your automatic, analysis fit what you'll be doing in this process evaluation. The goal with these first 2 is to make it as easy as possible, right? Make it feasible, make it perhaps enjoyable, meaningful to your teams, and then so you keep carrying them out year to year. Next, I recommend doing the quantitative assessment first so that you can really prioritize what you ask about in your qualitative section, and also save on time in that regard as well. And then lastly, cut down on research questions. The first year we had, I think, over 30 research questions, or able to pare them down to 17. And that really made it a lot more feasible for our teams, and also easier to complete again later. So that's it for me. Thanks, guys.
Thank you, Barbara. I think at this point, we're ready to move to Q&A. And there are a few questions here in the chat, some of which may have already been addressed. My name is Claire Boswell, by the way. I haven't spoken yet. I'm also with FH. And So I'm just going to read off a couple of these questions that have come up, and I think some of them may have been addressed, so you can tell me. Mary Packard, you were asking about some examples or detail and examples of how coaching and support is given as part of the feedback process, which are great questions. And there was a little back and forth in the chat, but I wonder if any of our presenters would be willing to dive into a little bit more detail about this. I believe this question was originally addressed to you, Violet. Could you tell us just a little bit more about that?
Just a minute, I have that thing. The first question that was posed by Mary, is that what you said, Claire?
Yes, if you could just give us some examples of the coaching and supportive supervision and how feedback was provided.
Okay, so what happens is that once we get the reviews done during the QIVC and we notice the training needs, because at the bottom is where there is a training need or any other help that that person or the staff or the volunteer needs, we actually have a timetable well planned for refresher courses and, you know, what is the feedback coming. We have a feedback kind of table set out or laid out, and this feedback helps us to actually plan for the coaching or mentoring sessions. So what is happening is that, one, we hold the staff accountable because each staff has volunteers they're responsible to. So these staff are the ones that are going to do the trainings, the support that is needed, especially in terms of if it's a training need, if it is a challenge with facilitation or materials needed. So this is done by our staff to the volunteer. And then to the staff, it is us, the specialists, myself, the health and nutrition, and the institutional capacity building. We put up sessions. We have sessions all across the financial year and in different kind of modules and different kind of trainings that are necessitated by the staff to improve and their training capabilities, to improve their knowledge, as well as how they are functioning in the communities, especially when they are in regard to the care group module. So that is what we have. Then secondly, we are also translating, we've translated most of these QIVCs and materials to the local languages for the volunteers to be able to understand them better. And then we go through, we use a native, a neighbor circle lady from that area to actually go through the tool. And then finally, before we even use the tool, we go through it with a different kind of neighbor circle women and volunteers to agree if this tool is making sense and even the material is making sense in their language so that they can own it and fully, you know, run with it. I think that is what we mostly do.
Excellent. Thank you, Violet. I appreciate that. A sort of a follow-up question on that issue. Barbara, you mentioned that you're using the feedback QIVC for the people doing the feedback supervision. Do you want to tell us a little bit more about that in terms of how that influenced the role of coaching and quality assurance?
Sure. So for those who are new to QIVCs, we have, you complete this checklist, yes or no, looking at, I almost kind of feel like we should pull it up at some point, but looking at various aspects that they complete, did they dress correctly? Did they, greet the mothers nicely? Things like that. We have a similar checklist that you use for watching somebody provide that feedback to the facilitator. So let's say that Karen was facilitating and Mary observed her. Mary would fill out the QIVC while Karen did her after Karen did the lesson, and then after the lesson, Mary would share that feedback with Karen. I would be watching how Mary did that and have my own checklist to look at to see if she adhered to various aspects of how we want feedback to be given. Because there's this idea of supportive supervision in that you don't want to, be punishing anyone or emphasizing negative things that they did, but rather start with the positives and really celebrate the things that they did well, and then mention just a few areas for improvement. And so there's this whole process for how feedback should be given. and there's a QIVC to help guide you in that process as an observer of the like that feedback session. Does that make
Excellent.
sense?
Yes, it does. Thank you. I think many of us have found that this idea of supportive supervision and really affirming people is a bit revolutionary in many of the places where we are working, and that's fabulous. Mary also had a question for you, Sadoc, about how you use the QIVC to really focus on the facilitation skills. You mentioned, as many of us who've used these QIVCs have noticed, that not all of these points on the QIVC seem to have equal importance. So would you mind sharing a little bit more about that for us, please?
Sure. So yeah, we took the QIVC as it was presented in the manual, and as we were using them, we noticed that some of the questions had more weight than other, as you mentioned. And I think it was mentioned by the other presenters as well. So things like the question regarding participatory methods to do the training with the mother groups, and asking right questions, and the way that the facilitator in general just passes on the information were the ones that we were taking more in consideration when we were doing this quality control. So yeah, according to Mato says, we hope it says that to usually this facilitator score 80% is a good score, right? But yeah, we were able to go deeper, more in detail with this, because we didn't have so many, we didn't have too many of these of the care group volunteers, right? We only had one promoter as well, and one supervisor. So it made it easy to do this kind of feedback and strengthen the capacities of the facilitator, of the care group volunteer, and the promoter. Now, as this project might increase, I think that's how we're gonna determine if we'll see how effective this analysis is. And that's why I mentioned about using the digital apps, right? Sometimes that can be really analyzed quickly using things like Google Forms or using CoboClick, because we have seen that experience. We have seen that the way that these apps function with other programs, right? But this experience with quality control of the care group model really helped also strengthen the capacity of the partner of quality control with other programs that they were already implementing. Although they've been partners with Renew for several years now, and we emphasize monitoring and supervision, I think this just added to that aspect of capacity building. So the experience with care group models, of using checklists and really looking into specific aspects that help strengthen the capacity of community promoters, especially, was really helpful, because, as I mentioned, it was just two staff persons originally. Then with the care group model, with the project, they had 4, but they rely a lot on community promoters, community volunteers, right? So using these qualitative tools help strengthen the capacity of them supervising and also training promoters, not just the care group model, but with other programs as well.
Thank you. Yes, we'll be interested to hear about your experiences as you expand and scale up. Thanks so much. Ira had a great question that we could open to anyone about this whole issue of the time requirements. We know that in the original design. It's all laid out neatly. And then Barbara explained how it doesn't always work out that way. And the time demands become very unrealistic for our volunteers. Would anyone else like to share if they've had a similar challenge, how they handled it, or even if you haven't solved it yet, what has come up for you and what you're thinking about? Just open it to anyone who would like to share their experience.
This is Mary DeCoster. I've observed a lot of care groups. I don't want to jump in if somebody else was about to share, but I've had the opportunity to see how they're done in so many parts of the world. Really fun. You can tell what's a high functioning care group right off the bat too, even if you can't understand the local language. But people do manage it a lot of different ways and adapt it to the local circumstances, and not burdening the volunteers is a high priority, you know. So some people do, I mean, there's a whole range. Some people do less home visits. I think it's sort of a side corollary that as you can build the really, really high quality of the group meeting, some groups only do home visits, by the way, but if you are doing the group visits, I mean, the group meetings, building that quality so that it's so much fun and you wouldn't want to miss it. And, you know, getting the information out to the husbands and the mothers-in-laws about the value of this for, you know, how this is helping your family and your, you know, the health of the children and the young mothers and so forth. I mean, getting them on board too is really important, but having those meetings be really fun and really valuable so that people are like, I would not miss it, as you build the quality. And I always feel a little bad if you're punishing the mothers that came on time by making them sit and wait. I mean, it would be so much better to start up some review activities or some games and sharing, you know, just the support group aspect of it. Don't sit quietly, you know, like start up something, would be a high recommendation of it related to that problem that Barbara brought up. I don't know if this is answering the question or not, but it's just kind of that there are lots of options, and I think it's nice to explore with the volunteers and, you know, locally how you're going to solve it. Good luck. Anyone else?
Yeah, I was just going to mention to you that everywhere kind of handles it a little bit differently. And some areas that I've seen, I haven't seen as many as you, Mary, but the groups that I've seen, sometimes they alternate. So maybe the first visit or the first activity in the month is a group meeting, and then they do the next one a home visit, or, you know, they do a certain number of home visits per quarter and the rest is all group meetings, or it's all strictly home visits and there's no group meetings. So it just, I think yeah, they just have to figure out what works for the mothers best, and then go with that and just kind of test it out and see. Sometimes I think also it depends on some of the content being discussed. Sometimes I think there are topics that tend to be, I don't know, more easily discussed in a home visit, you know, a little more privately and not in a big group. But I think that's also depends on the area, you know, the country or the region that you're working in.
Right. This is Nancy with World Renew, Bangladesh and India primarily. And I wanted to agree with Mary and Karen that I think I've seen the volunteers kind of work it out as they go. Often I've seen a mix mainly in both group and home visits, but often I find the home visits, yeah, it's like what you just said, Karen, when it's on a sensitive topic, looking at the timed and targeted counseling part, For certain parts of it, they'll do or reinforce at home with specific mothers as they know their mothers. So they really encourage the group work, but also then really highlighting who those mothers are. And as the volunteer knows the mothers that they're involved with in their communities. So we found that as well. But I see it used in different ways, and I see the volunteers working it out as they go with promoters and facilitators. So that's been nice to see.
Yeah, this is Ira Sadoc. I work with Barbara, who is Curamericas. And one thing I've observed in our Guatemala project is that since it's really not practical to visit every woman after every lesson, the home visits tend to be prioritized, and the care group volunteers they're called educadores, tend to work very closely with the equivalent of the community health workers, the educadores. And so those mothers who are having the most trouble practicing the behavior, whose children have the more frequent health issues, like a malnourished child who needs frequent growth monitoring. Those are the ones, there's a lot of communication between the comunicadora and the educadora. And then the home visits tend to be, because we can't visit everyone, they tend to be focused on the high priority mothers, the high priority households. And sometimes I've seen them both there together, the educadora and the community health worker, working in tandem with the community health worker, handling the things like weighing and measuring the child, and the care group volunteer focusing on the lesson material.
Thank you all. I love the creativity and how programs are addressing these very real problems. A follow-up question, which I think is related, that Zamach was asking about the role of the husband of the care group volunteer. And Barbara, you mentioned that was one of the challenges. Actually, it was the role of the husbands for the neighbor women. I wondered if any one of you would be willing to talk a little bit more about that, the challenges that you might have seen with male support for both the volunteers and then for the neighbor women and their participation in any creative solutions you've had.
Maybe let me just talk about the Uganda experience. We're conducting a gender analysis as well as a study just to find out what the males have in one of the refugee settlements that we are implementing. And the results came out that since we are implementing these care group models in a male-dominated society, the male feel like they're marginalized, and they feel like their women are being educated to actually not to disrespect them, not to follow them up. And also we are giving them a lot of opportunities to develop, maybe improve their livelihood, and it's making them kind of like grow wings in their households. And so, not even listen to the men. So we realize it's bringing some kind of friction in these households. And for some of the households, we're seeing an increased intimate partner violence happening, of course, due to other issues as well. But one of them is that the ladies, being that they are able to meet in these care groups, realize it actually treats depression. At the same time, it empowers these women to actually be able to speak and make decisions because of the trainings that they have undergone. So what happened is that we thought of ways together with the volunteers and the neighbor circle members, how to bring on the male gender into this care group model. So what happens is that it's the volunteers who would actually pick a male champion, because the volunteers are coming from 12 households. They know the males within those households, how they're behaving. And then they would choose a male champion. This male champion is the one who recruits either 12 to 15. And then that is what we call a care group, because for the males, they cannot be, not so many of them are actually willing to participate. They only come in when they are kind of like motivating factors in terms of using the same group as a farmer group or as a VSLA group. So we had to enroll these men into these groups, and we started with 6 so far. And in that particular cluster, And then we saw that they were trying to meet, but they would not meet as regularly as the women. So we had to bring in motivating factors. And this is where we started integrating this care group for especially the men. Even the women now, we do it with livelihood options, where we are including the VSLAs, we are bringing in the farming kind of production and animal production. And now because of COVID-19, we are bringing in trainings for soap making and all that. And so once we saw this working, especially in bringing about increased acceptability and uptake of use of some of the behaviors that we wanted to change, we actually decided to roll it out to other districts that we're implementing in. One of the key behavior that we saw was really being encouraged by the men after this group was the family planning uptake, because it was very bad. I think before the module, we actually did a pre-module assessment, and it was only around 36% of the women who are using this, and most of them could not even tell their husbands. But after the first trial with the males, we saw this rise to 56. And I think lastly, I think the final one that we have done in this particular area and in another district has gone to 70%. So for us, we've seen some good improvement with involving the males in these actually groups, and it makes the uptake of the new behavior you're trying to bring on board much easier. Thank you.
Wonderful. Violet, thank you so much. That's fascinating and such a great example of how your monitoring allowed you to observe this problem and then come up with a pilot and an expanded solution. That's fascinating. Barbara mentioned that it would be great to have a whole session on male involvement. It might be something for us to consider for our next meeting, because I'm sure that we all have a lot to say about that. I think at this point we're closing in on our stop time, and we just wanted to remind you all that the resources will be sent out, the recording and the presentations, so you'll have access to those. And if possible, any of you want to hang out for a little bit longer past 10:30 or whatever time it is where you are. Maybe some of the presenters, if you have time, could hang out. We could talk a little bit more. It's completely up to you, but I want to respect those of you who have other meetings or other responsibilities for us to close on time. So I will open it up to, you can either respond in the chat or open your mics to see if a few of you want to hang out past our time. Otherwise, we really appreciate our presenters and the great questions that were asked. Very good discussion. Okay, so Barbara says she can hang out. If anybody has further questions for Barbara,
Great.
just wants to talk about anything. Sorry, Karen, go ahead.
Oh no, I can hang out too. I also wanted
Okay,
to
great.
mention for those of you who maybe would like to try using QIVCs, haven't used them before, the TOPS care group training manual has a lesson on how to get started. It's lesson 12, and I don't know if anyone has that link kind of handy to use it, but it has a really good training session on how to get going on both the QIVC of the meeting, the care group meeting, and then supervising the supervisors that Barbara mentioned. So both of those tools are in the care group or the care group training module manual, sorry, from TOPS. And those are just general tools to help you get started with your team. So to be adapted in your context.
Super, thank you, Karen. And Barbara offered to share a template she has as well. Be great to, we'll try and get those from you and send them out with the, oh, thanks, Kim, with the email of the recording and the presentations.
Yeah, and Nancy Tenbrook was reminding me in a side conversation about how helpful Make Me a Change Agent also is on a number of the skills as well as the actual QIVCs, but the listening skills and the asking open questions. I don't know if you wanted to say a little bit about that, Nancy. I'm stealing your thunder now. I just was afraid it wouldn't get mentioned.
No, I just thought it's really, really useful because as you know, you all shared the challenges and so forth, and we found really working first with the staff and then with, you know, the volunteers and so forth, but working, what I like about Make Me a Change Agent is it's not, you don't have to use it as a workshop. You can just share bits of the lessons when you're coaching. So we found, you know, after working with staff on it, it really can be used in these sessions for coaching. And that's really been helpful in the work we've been doing. And then working on those QIVCs to accompany with it a lot of the different tips from Make Me a Change Agent.
Thanks, Nancy.
Hey all, this is Kim, and I know that the session is ending. I'm just going to stop the recording and then you guys can continue to chat, but just realize that this will be the end of the session right now.